Okay. My name is Tom Ferris. I'm the director of the Center for Health Organization Transformation. Beta Cash is our center co-director, and Lauren Erlinger is our managing director. We put this quick presentation together, but it took a lot of people's inputs. Thank you all very much. Again, I am recording this meeting, so we can make that available later for those taking notes. The goal here today is to talk about how we as a center and our network of people involved in our center and those who could be collaborating with us can mobilize to address this threat. I do want to point out very quickly, our structure. We are a National Science Foundation industry university cooperative research center. What that means is that we are a group of academics working very closely with members of industry. We get our research directions from our industry members, and we collaborate with our industry members. This is important because we're academics. We are not on the front lines like the people who are dealing with this threat. I do want to just point out our website for those who want more information. You can find a lot more about our past work, our current projects on that site. Welcome everybody. So this is a lot of people were coordinating for our annual spring meeting with the Center for Health Organization Transformation, and this is now taking the place, this meeting right now, which is we deem more urgent, more important than our usual reporting on our results and talking about the next cycle of research. So we're focusing everything on our current COVID problems. We have 6 university sites that are affiliated with our center. We have 35 plus or minus industry members, and we represent care providers, we represent payers, we represent government agencies, we have medical device companies as part of our membership. And so what we like to say is we are a healthcare systems problem-solving organization in that we can look at issues with healthcare at many different levels, many different aspects of providing care. And of course, we want to especially welcome the visitors who have joined us today. We have several really excellent world leaders on the front lines of the research for this problem. We also have several friends, colleagues, and people who want to help joining the call. So thank you all. We have some special guests today. We're going to do a little bit of a rearrangement of the schedule, but I just want to quickly introduce them, and I have to bring up my notes on that. Just a second, sorry. So actually, I'll just speak in the order that we'll see them. Oops. So Ms. Grace Simral will be our first guest, and she is the Chief Innovation and Technology Officer for Louisville, Kentucky Metro Government. So she's responsible for advising the mayor, leading the city's Smart City Initiative, transforming the resident experience of digital government, and facilitating the creation of breakthrough civic innovations. We also have Dr. David Wheelock, who serves as the Group Vice President and Deputy Director of Research for the Federal Reserve Bank of St. Louis. We have Dr. Jean-Francois Petit, who is a David Hill Chestnut Endowed Professor and the Director of the Organ Injury and Trauma Research Department, and is also the Editor-in-Chief of the journal Anesthesia and Analgesia, and is a practicing anesthesiologist. We also have Dr. Christopher Murray, and he serves as the Director of the Institute for Health Metrics and Evaluation. His career is focused on improving health for everyone worldwide by improving health evidence. You may have heard of the Chris Murray model, which is being on a lot of major news outlets, informing a lot of government decisions right now as far as forecasting the spread and the need for resources in this response. And our fifth speaker is Dr. Micah Ensley, who is a human factors engineer and the former chief scientist of the United States Air Force. She's also a former past president of the Human Factors and Ergonomics Society, and she'll be able to speak from her perspective, both governmentally and as a leader in the human factors community. So thank you all very much for joining today and you're giving your valuable time. I want to lay some quick ground rules. So we're in Zoom here is our software that's helping us out here. Please, you will be muted by default when you join. And so that button right there, if it looks like that, you're not muted. If it looks like that, you are muted. Please do that so we don't have background noise. We all think it helps if there is video enacted when you are choosing to speak. This just kind of helps us all get a richer experience in understanding what you're talking about. So use that if you're able. If there are internet problems, by all means, you can turn off the video. That may make it better. The way that we want to handle questions and discussion are two ways. So first of all, please, any substantive questions that don't need to interrupt anybody, please enter them into the chat window. And Lauren, our managing director, is going to be watching that. And when we have a moment to ask those questions, she can read them out. But also, so please enter your questions via chat if you can. If we open the floor for questions, then you're welcome to vocalize. But the way we want to do that, because of the number of guests we have, is to please use this raise your hand function. So if you click on this manage participants, or it'll just say participants or something for you, the participants will pop up. And then you click this button here, raise hand, and Lauren and our student workers can be watching and can also help me if we're yapping too much and you can interrupt. So please use the raise hand if you want to interject something. Otherwise, let's use the chat function for questions for now. Thank you. Final-ish thing from me here is we want to know who's on the call. And so this is for NSF record keeping, but also for us, so we can follow up with the conclusions we have here today. We can get back in touch with those because ultimately we will be forming work groups around some of the directions that we can go with the research here. So please let us know who you are. Either, in the Zoom chat, you can say, here's me, here's my contact information that you're willing. I mean, if you're putting it in the chat, everyone will see it. So you may instead wish to email, and you can email Lauren Erlinger, our managing director, LIR. You can see it right there. You're also welcome to email me if that doesn't work. Okay. I hope that I've just introduced the talk, and we've got a slightly rearranged schedule here, and so I apologize this is not updated, but we're going to go into some of our expert speakers right away so that they can get their word out. We can have a chance to do questions and answers. For the most part, we've asked each of our speakers to take about 10 minutes if they'd like. I will not stop any really fruitful conversations, but we will try to keep on task. So I may interrupt and move things along. If we do that, we can have offline continued conversations, or we can follow up with email. We also have two of our current center members who have already begun work with some research on the COVID-19 through the NSF Rapid mechanism, and they're going to talk about their projects, and that may feed more discussion there as well. At the end of the call, then, we're going to have an open discussion. We will coalesce to some working groups then as a center, which we will coordinate proposal writing, will coordinate these activities. Without further ado, I would very much like to introduce Ms. Grace Simrall and hand over the floor to her. And for all of our speakers, I'm moderating, Lauren is moderating, so we can help with anything. But I will turn the floor over, and questions and answers, again, please via the chat box. Thanks, Ms. Simrall.
Thank you, Tom, and thank you, other CHOT members, and thank you for the adjustments to the schedule. A little bit about Louisville Metro. We are a combined city-county government. We merged government back in 2003, and as such, we are responsible for our local county's response to COVID-19. Our city is the largest city in the Commonwealth of Kentucky. Our actual, again, because we're a city-county government that's been merged, our population size, as recently as the most recent census, is 765,000 residents. But our larger MSA area is about 1.2 million people. And because of that, Our local government, as it relates to COVID-19, is experiencing strain across every single aspect of the system. I mean, whether it's organizationally, so we have implemented the incident command system to try and address this, but we've rapidly realized that the rigidity that's in place for the ICS, which is normally put in place for things like emergency response, is really not the exact right structure for us, and we're making adjustments to things like disease surveillance. So our inability to get adequate testing kits and supplies to be able to do widespread testing poses a significant challenge. System of record. We are struggling between state and local, let alone the federal government, to be able to have a single source of truth. It's nearly impossible given the fact that we have such a fragmented healthcare delivery system. Everything from what local county public health officials are doing to what's happening at the state versus what's happening at the federal government, both at the CDC as well as HHS. And then you've got the privates involved in this, so that's hospitals as well as labs, all using different systems, all reporting at different scales, all using different communication channels to be able to report. Some places have systems in place that are digital, some other places are using fax and hard copies to be able to communicate. Incredibly inefficient and very difficult to get a sense of what's going on. Our supply chain has basically become completely broken. Our local government has had to be very judicious about how it handles, in fact, our own cleaning supplies. As you can imagine, a local government cannot just shut down, unlike other private companies. We absolutely have buildings that cannot close. And so being able to even ration cleaning supplies for those is incredibly challenging. Our ability to obtain PPE is, as you can hear on, I think, across the board, local, federal, state, an incredible challenge. And so how do we coordinate with, in particular, universities and leverage their expertise around both better manufacturing as well as breakthroughs around engineering. So, I think everyone hears about how ventilators are in short supply. And so the ability to extend safely ventilator usage so that it supports more than one patient is something of great concern for local governments. Therapeutics. So our ability, for example, to better manage surge by reducing the length of stay for those who are in intensive care and or on ventilator makes a tremendous difference in our ability to do hospital capacity planning. And more about hospital capacity planning. Modeling is a great concern. So I'm so glad that Dr. Murray's on the call. We, have been scanning for weeks what available models exist, both starting with what Wuhan was publishing, what Chinese researchers were publishing, but looking at, in fact, in great interest in what IHME has done. I have actually quite a bit of feedback on this. Certainly, it's interesting from the state level. Local governments absolutely need better access to it. We can try and do our best to estimate how we could, at the very least, look at proportional medical service areas and make determinations. But there are some assumptions in the model that we just have to make different assumptions. So including the average length of stay on ventilators and the average length of stay on ICU beds, I think is very different than what the model, at least is assuming for Kentucky. And then I want to spend a little bit of time talking about equity. So we have a lot of challenges, and you can see this again at the federal, state, and local level around making sure that our policies are equitable. So let's take the federal government, for example. It's been announced that very soon families who have direct deposit information with the IRS will be able to get their checks, but many in our community who are in fact the worst off are unbanked, and they're being told that it will take 20 weeks for them to get their checks, which is really unacceptable, and again, speaks to the challenges we have around equity. At the state level, SNAP benefits and the timing of available groceries and badly needed supplies at retail stores are again off, and those are on SNAP benefits are struggling to be able to get the supplies they need. At the local level, enforcement of social distancing oftentimes can be perceived as inequitable. To give you an example, in Louisville, Kentucky, we have residents who have been engaging in very dangerous drag racing on our streets. These residents happen to be African American, and we have the ability, for example, because this is an illegal activity, to take further enforcement activities like impound their vehicles. At the same time, we have young people who are not African American not engaging in social distancing in parks. They're playing basketball, they're playing frisbee. These are not illegal activities. At the same time, it's perceived, or they're golfing. We are kind of bound by our ability to enforce social distancing through the law. Predatory practices. So again, in our community, we've had these pop-up tents show up where individuals are claiming that they can provide COVID-19 tests to individuals. They're showing up in neighborhoods that are historically disadvantaged and charging $250 a test, when we know that, again, these probably are not actual real tests, and they're being that there are people taking advantage of the situation. So just a call out that as we look at these responses, and as you can hear about just the grand challenges across all of these different systems, that we also can't lose focus of the equity aspect of our response. And with that, I'll pause and see if there are questions.
That's wonderful. Thank you so much. If anybody has questions, can raise hand, or we can read the chat. There's a lot of really useful information. Thanks very much, Grace.
I don't see any questions, but I will say the reason why I had to be moved up in the schedule is that I am responsible for the Metro developing our situational awareness dashboard on this. And so we have done everything from identify, again, just at least get a current state around confirmed case counts and presumed case counts, but at the same time, look at models such as the one at IHME to begin comparing that to what is forecasted, and then look at actual hospital capacity where we are, identify surge capacity plans at the hospital, figure out that headspace, and figure out the trigger points at which we enact those various different interventions, such as aggressively setting up field hospitals and or other types of non-acute care settings to be able to start moving patients to those settings.
Good morning. This is Ken Cochran, and I joined late, so I apologize if I answer this question or make the statement and it's not what you're looking for. But in Louisiana, we do have a surge report now that tells us by parish, by city, the number of state tests, commercial tests, positives, number of deaths by parish and by city. And then by region, we now have a list of both tier 1 facilities, which would be your traditional settings, and then your tier 2, the non-traditionals that are being set up. And then it breaks down hospitalizations and overall bed capacity, as well as ICU capacity from pediatrics, with adults and pediatrics. And as we heat up, that will become very useful for us to know who to even bother to try to call when we need to transfer patients. Was that what you're asking about, like understanding the capacity and the ability to sort of understand what's going on in the region better?
No, I think we actually have a pretty good handle of that. So I have a good sense of actual available capacity. What we are struggling with is, what is the actual needed capacity? We're still in the early days of both testing and again, lagging in the time from when we had social distancing policies put into place versus when cases show up in the hospital. So getting a really good sense of both the timing and the magnitude is going to be really important for us. I need to know, like, if I have, let's say, 300 ventilators on hand across our hospital systems, is that enough? The answer is probably no. In fact, given the average length of stay on ventilators is looking like it's 14 days. We need to make sure that we have enough so that we don't just have enough on day one of the surge, but through days 2, 3, 4, 5, etc. Does that make sense?
Yep. And that's that has been the $1 million question.
Thanks, everybody. I'm sorry I'm going to have to let Ms. Simrall go. Thank you very much, Grace, and thanks for the questions. If there are additional questions, we can follow up via email, but we're going to keep moving for the sake of time. Thanks very much again.
Very good. Thank you all.
Okay. Thank you. So our next speaker will be Dr. David Wheelock. Is Dr. Wheelock on? Yep, I see him there. Thank you. So Dr. Wheelock, I have already introduced you, but you're Group Vice President and Deputy Director for the Research Federal Reserve Bank of St. Louis. I'll turn it over to you. Thank you very much for your time.
All right. Thank you very much. It's a pleasure to be with you. I hope everyone can hear me. Tom, okay, good. I am at the Federal Reserve Bank of St. Louis. We're one of 12 Federal Reserve banks scattered around the country. In addition, of course, there is the Board of Governors of the Federal Reserve System in Washington, D.C. We're all working intensively to monitor the U.S. economy, the world economy indeed, as well as to try to come up with responses to the economic consequences of the pandemic event. Let me say at the outset, of course, that my views today are my own and not representative of official Federal Reserve positions. So I think I'll try to give a high-level overview of the impact of the virus on the U.S. economy. I think it'll be complementary to the previous speakers, very micro-focused at the problems on the ground in a particular city. Louisville happens to be a city where the St. Louis Fed has a branch office. So that's very interesting to me. So the U.S. economy has clearly been in a nosedive over the past 2 or 3 weeks. Nearly 10 million individuals filed claims for unemployment insurance in the past 2 weeks. The number of 6 million new unemployment insurance claims just past week was 10 times higher than the previous record high for a single week in the U.S. history since the data go back to the 1960s. In addition, just this morning, the March unemployment report was released, 700,000 jobs lost in March. That probably understates the true number because the survey was done in early March. We know there have been a lot more since then. So I expect a much higher figure, a decline in jobs and increase in the unemployment rate for April. Aside from layoffs and furloughs, just in the past few days, we've seen sharp declines in purchasing managers' indices, sales of cars and light trucks, consumer confidence, a number of measures indicating that the economy is in something of a free fall. Recent tracking forecasts for the U.S. economy indicate that U.S. GDP likely declined about 3 percentage points, or about 3% rather, in the first quarter, with all of that coming in March. Economic forecasts for the second quarter are quite grim, with some private forecasters predicting a decline in U.S. output of 25% or more, and an unemployment rate of anywhere from 10 to 30%. Goldman Sachs, for example, forecasts a 34% decline in U.S. GDP in the second quarter and an unemployment rate of 15%. The Blue Chip Consensus forecast, a compilation of forecasts of private forecasters from around the country, is somewhat more modest than Goldman, but the consensus sees a 16% decline in U.S. output in the second quarter and a peak unemployment rate of over 10%. The decline in output, by the way, if it's double digit like that, would be the largest single quarter decline in U.S. GDP since World War II. So when and how fast the economy recovers will, of course, be dictated by the pandemic and the measures to slow the virus's spread. Some economists believe that the economy will begin to recover in the third quarter, and that output could snap back rather quickly, the so-called V-shaped recovery. Goldman Sachs, for example, sees a whopping 19% increase in GDP in the third quarter, largely on the strength of all the fiscal policy that the federal government has enacted. But that's an outlier view, to be sure, but indicative of the hope for V-shaped recovery. As a baseline, the president of the Federal Reserve Bank of St. Louis, Jim Bullard, expects a very large decline in GDP in the second quarter, with the beginnings of recovery in the third quarter and a strong rebound in the fourth quarter of 2020 and first quarter of 2021. Importantly, and I can't stress this enough, the forecast is conditional on the coronavirus being sufficiently contained to allow a widespread reopening of businesses and schools. An increasing number of economists are less convinced that we'll have a V-shaped recovery. The pandemic is the fundamental driving the US economy right now. If it takes longer than expected to flatten the curve, or if there's a major second wave in the fall and winter, then social distancing restrictions could be reinstated and the V-shaped recovery becomes less likely. The upshot is that the timing and the pace of the economic recovery will depend heavily on the evolution of the pandemic. The longer it takes to get the pandemic under control, the more protracted the likely speed of the economic recovery. Both the Federal Reserve and the federal government have taken significant steps to try to cushion the economic blow for households and firms. The Fed's main role is to ensure that financial markets continue to function, and that starts with the US Treasury market. The Fed has acted to relieve strains in the Treasury market through outright purchases of securities, as well as by taking several measures to ensure that other participants in the market have sufficient access to funds to enable them to continue to trade. The Federal Reserve is also in the process of rolling out programs to support the commercial paper market, longer-term corporate debt markets, money market mutual funds, and to provide loans to small and medium-sized businesses. So I think I'll stop there. I'm happy to take any questions, time permitting.
Thank you very much, Dr. Wheelock. And for those of you, I didn't give enough of a disclaimer here at the beginning, so this may have sounded a little different than the healthcare-related conversations. We asked Dr. Wheelock to please join us because the health of our country is more than just physical health. It's also our social and economic health. So thank you very much. And if there are any questions, I'll shut up now.
Hey, Dr. Willock, this is Theo Edmonds in Louisville, Kentucky. I have a quick question for you. Are you seeing anything or any kind of indication in the macroeconomic data that is predictive of our ability to innovate, especially in high-touch, high-tech sectors like healthcare, where we depend on that frontline employee as well as the technology to advance the sector and move forward? Because I've noticed that trust is breaking down among different layers of society right now, and I'm wondering how you all are thinking about trust as an economic factor in society.
Well, I think it's very important in a broad sense. Consumer confidence is way down. Business confidence is way down. There's an awful lot of uncertainty. If you just look at the stock market, at the gyrations in the stock market, that's very indicative of a high degree of uncertainty about the profitability of U.S. corporations, frankly, and that ultimately depends upon the broader macroeconomy and the ability to get the pandemic under control. So, we're not seeing it so much at a micro level, but you say these economic factors are very important. And President Eric Rosengren of the Boston Federal Reserve Bank gave a speech earlier this week where he emphasized the importance of confidence and for example, at a very simple level, you remove restrictions and allow restaurants to reopen. The public may not patronize those restaurants, if they're still fearful that it poses a health risk. So, it's a very important element. I agree. Yeah. Tom, I think you have your mic on there, or your mute on. So.
Thank you. Thank you. Yes, we have one more question from the chat from Judah Thornwell. Are there any thoughts on which specific industries will be most impacted or specific impacts on the healthcare sector? And I'll let you answer that, however. Thank you.
Sure. I think clearly the pandemic and the response to it have had significant impact on travel-related industries, the restaurant industry, the airlines, and so forth. The front lines that are, in terms of social distancing and so forth. We've done some research at the St. Louis Fed that has looked at specific industry groups, specific parts of the country where, in jobs which require a lot of human interaction, people can't work at home. And then obviously it's had a major effect and will have probably a lasting effect on the healthcare industry. And my sister, for example, lives in Washington State, and she was until recently the head of a modest-sized medical center there. And she reports that it's particularly difficult for smaller hospitals and medical practices that really don't have the financial resources that maybe some of the bigger players do. So, we'll undoubtedly see some transformations going on in the healthcare field. Another area that's going to be impacted, I think, is the retail sector. We've seen for some time struggles of brick and mortar retail stores and growing use of online platforms for commerce. And this event will probably accelerate that trend as well. So those are just a few examples I can think of off the top of my head.
Dr. Wheelock, I want to thank you one more time, and we'll move on to our next guest, but we really, really appreciate your time. Thanks for the good questions from the crowd as well. So have a nice day, and I'll move on to our next speaker here. Dr. Jean-Francois Pété. Dr. Pété, I don't forget to unmute your mic, I see, but welcome and thank you for joining us.
Yes, thank you very much. I would like to thank Dr. Borkowski from UAB and you to invite me to this meeting. I am indeed a professor of anesthesiology and surgery at the University of Alabama in Birmingham. I have also a position in the University of California, Los Angeles, and I am a practicing critical care physician, and I do also a lot of research. It is funded by the NIH and the DoD, and I'm finally the editor-in-chief for one of the major anesthesia journals in the world, Anesthesia Analgesia. Next slide. I prepared 3 slides to summarize my question. I got 2 questions. What is my perspective on challenges of delivery care in today's COVID environment? And the second question is how could we move forward? I'm not pretending here to be comprehensive, but I try to bring to you what are the issues that we are dealing with. The first one is the disease itself. This is a new virus with very unclear pathogenesis on multiple organs. I'll give you an example. The lung injury that we are seeing with this patient, or with COVID-19 patient, is different than what we are seeing with the flu or after sepsis, bacterial sepsis or trauma. And the way we treat this patient is likely to be different. Second, the variable host response that is not fully understood. We understand that older people, the people with comorbidity will be very sick and die from it. The question is why a 25 years old become very sick and die, and the next one is asymptomatic. We have no answer to this question, and this is very critical to understand. Number 3, the lack of effective and specific treatment. We do not have, honestly, today we can say that we do not have a specific treatment to treat this disease. We have a lot of potential drugs, and the problem is that we have a massive number of low-quality scientific reports about this potentially new treatment that are often contradictory. And this is a big problem because it questions what we should do with this patient, particularly when they are not doing it. The next issue, which I think is very important and is coming, is the large number of patients during the surge that will quickly overwhelm our emergency room and ICU team. And we are trying to deal with this preventively, but our team number is limited, and this is a big problem. As you know, in New York, there's been a call for a physician to go to New York to help the hospital. They are completely overwhelmed. I have some of my editors for my journal working in New York, and they said the same thing. The next issue, which I think is not unimportant, is the relative lack of personal protective equipment that is available to the frontline healthcare worker, that will force the reutilization of an equipment that is not meant for reuse. And there are several proposals how we can clean this equipment. The problem is that by cleaning the equipment, particularly the mask, the N95 mask, you can damage it. The potential lack of ventilator will force, at one point, possibly, the ICU care team to make decisions about whom will benefit from medical ventilation and who will be denied it. In Alabama, we have a state law that said that in case of massive emergency, the family is not the last person, that are not the last to make decision. We can make a decision with the ethics committee of the hospital. Then the emotional stress and fatigue of the ED ICU team, which are dealing with a potentially deadly disease, for which we do not have specific treatment. And we are trying we completely reorganize our team. We're giving at UAB 1 week on, 1 week off, to give enough time to recover from this stress. Because any mistake can be very, very serious. Finally, I want to mention also the lack of understanding of the long-term effect of the COVID-19 disease. We know from bacterial pneumonia that if you look at 1 or 2 years, the mortality is much higher than what you have after 1 or 2 months. And I'm involved in clinical and basic science research funded by the NIH to try to understand this. It could be that the COVID-19 is causing the same type of problem, but we have no idea at that point. Finally, not directly related to the COVID-19 itself, the cancellation of all elective surgery with no information about when this surgery could be rescheduled is a big problem. It's not only a financial problem, but it's also a problem for the patient. And I mentioned finally the economical consequence of this cancellation of surgery and the regular visits to primary care and specialized physician is dramatically affecting the this smaller medical group. The next slide will show you in one picture, if you can show this, the situation. Can I have the next slide, please? Yes, this is the extension of the emergency room at Vanderbilt University in Nashville. It's been organized as the parking garage of the hospital. So this shows you exactly what is the problem. Next slide. So to finish, the question is, what are my advice? I would say, what can we do to moving forward on the delivery of care as to the COVID environment? I think we absolutely need an increased financial support for studies that focus on the understanding of the pathogenesis of the disease, basic science and clinical study, new effective treatment and development of safe vaccine. When I hear, Anthony Fauci and others said it will take a year and a half to get a vaccine, is very concerning. I hope it's not the case. I hope we can get this faster. I think what we can do, as I mentioned it before, is a restructuring of the shift schedule of the frontline healthcare worker to provide maximal healthcare delivery as sufficient rest, 1 week on, 1 week off. Increasing the availability of the personal protection equipment and ventilator to optimize the protection of healthcare worker and the treatment of this patient. We need to address a very important issue. We need to address the challenge caused by the no visitor policy in place in most of the hospitals. These patients are not doing well. Some of them get intubated, ventilated, and die, and they have no loved one next to them. And this is a big, big issue for the people who survive and the person who die. Developing telemedicine in our RED department and ICU ward, I'm very involved with this at UAB. Actually, I'm pushing this because it helps to keep some of our physicians at home and not necessarily in direct contact with the patient. Increasing the testing of the population in order to better understand the epidemiology of the disease. We don't know exactly how many people are infected. And this, all the models that are made are based on the data that we have today. And I believe that we have many more people infected, but are symptomatic that we believe today. Finally, we absolutely need to increase the financial support to the hospital in order to preserve the salary of these frontline healthcare workers. It would be catastrophic if we realize that these healthcare workers are not getting their salary, are getting cut off. Currently, everybody is very motivated. The job that is done by these people is incredible. But I think we, as you know better than me, the hospital are running on a very small margin now. And the cancellation of surgery, particularly elective surgery, is a big problem for the financial aspect of the hospital. And finally, we need to plan in advance how we will organize this regular surgery, this visit. It cannot, if we don't do it, we will have a major problem when everything is slowly lifted. Thank you so much for giving me some few minutes to present this presentation. Thank you.
Thank you very much, Dr. Pide. And we have a hard stop here in 1 minute, and so I will say, if there are chat-based questions, we can feed those to Dr. Pide. We can cover them at the end. But here at 11:15, we have Dr. Murray joining us, so I don't want to get too far off the schedule. Are there any, well, it's 11:15. I'm going to go. Thank you very much, Dr. Pide, and we will follow up with additional questions. This has been very helpful. So I'm going to move ahead here. Sorry, that a little preview here. Oh. And Dr. Murray, if you're available, thank you very much for your time, for joining us, and I can turn over the floor to you, please.
Yes, thanks, and good morning, everybody. That's a photo that is very old. I had hair in that photo. Just I think the main thing to talk about is our effort that started here at our hospital system at the University of Washington to surge plan. We developed a health service resource planning tool that predicts hospitalizations, ICU need, ventilator need, and deaths. And then we scaled that to a number of other hospital systems in the state and then in other states that wanted the similar resource planning tool. And then because of demand, we just produced it for every state last week. And then the White House adopted our tool because we're essentially the only planning tool at the state level for FEMA to do allocation of things like ventilators. And then since that, we have been trying to get, when we first released the planning tool, all we had available on practice patterns for COVID patients was what CDC had released from a very small early sample of patients, where, for example, the ratio of hospitalizations to deaths was about 11 per death. And our model predicts death and then backs into the hospital resource use. And what we've now had is a flood of data from different states. We've got all the very detailed data from New York and Ohio and Rhode Island and now Washington State, and I think a number of other states overnight as well. And what we're finding is that the ratio of hospitalizations to death is varying quite a bit by state. It's not 11. In New York, it's actually under 5. And we think that's because they're triaging and not admitting many patients that they would have admitted in the past. And it ranges from between about 5 to 7. What that means is that tomorrow in our daily update to the forecasts, we will now use all this data, and that means our forecasts of hospitalizations will go down quite a bit, because we will go down from about 11 to around 6.5, but we'll use each state's data where we have it. But that's a general number. But the other thing we've learned in the last week is that length of stay in the ICU is longer than in the original set of patients, or in Italy, where was some of the other data that was available. And that longer length of stay means that although admissions to the ICU in our forecast will be down, the longer length of stay means the reduction in ICU demand will be less than the demand for the reduction in hospital bed demand. So a number of changes coming. Clearly, from the point of view of planning resources, the really big issue is whether our forecasts of the peak are correct. And that is really the big issue. We've built our forecast model. It's a statistical model. It's not a transmission dynamics model. It's a statistical model. And the main driver of that statistical model is the experience in Wuhan and the timing from putting in social distancing measures to the peak of death, which was about 27, 28 days, and the timing to the peak of hospitalizations a little bit earlier. And that's what drives our estimates of the peak. And so we are very keenly watching, and it's starting to look pretty confirmatory, the peaks that are happening in parts of Italy. And so the peaks in Italy appear to be sort of right on where we predicted them. And that's making us feel a little bit better about the nature of our model. But of course, we have quite wide range and uncertainty intervals. And we have a sort of more rigorous approach to trying to estimate the uncertainty in our forecast by looking back at how well we've been forecasting from the beginning, and that'll also roll out tomorrow. So those are sort of the high-level messages. We are working rather closely with the White House task force, and now increasingly many state houses, some of the larger cities as well, of trying to tailor the resource planning down to their locality, such as LA and San Francisco and New York City. And we are also trying to respond to hospital systems that ask for help to tailor our model to their specific catchment area. And that's a service that we'll try to meet the requests that different hospital systems may come up with. I think the last reflection is, what do we do when this first wave is over? If we are right, the first wave will be largely over by early June, but a very large fraction of the US population will still be susceptible, meaning reintroduction of COVID into a state or into the country at that point could lead to a similar sized epidemic. There are lots of unknowables there, seasonality that we don't know about, but at some point, reintroduction is going to occur, and at that point it will matter very much what's put in place to try to stop general community transmission. Less of an issue for the clinical services, but a huge issue for us all in terms of economic impact, health impact. And I think that's where already a lot of the strategy discussion is moving to, even as we go through in the next 2 weeks, this sort of critical pressure on our hospital systems. So quick comments there. I think there's a few minutes to take questions if that's useful.
Yes, we have a few minutes for questions. Thank you. And I'm realizing the timing we have for questions and the rapid fire here may make it that we can follow up via email as well.
So anybody with a question?
Good morning. I have a question. Are you all able to hear me okay?
Yes.
Okay, great. Thank you. Thank you for your presentation. My name is Brandy Kelly Pryor. I'm really curious about how concerning issues of equity and racial disparities that are relating to the data that we're seeing right now, especially some of the data that's most recently come out of New York in terms of mapping the boroughs that are hardest hit and how they are being, the individuals that are impacted due to death versus those who are due to transmission and diagnosis. Do you have any insight for us in terms of how other states and or maybe jurisdictions are collecting that type of data as it relates to racial breakdowns?
You know, I don't think much is happening on that front, to be honest. I think as we're seeing in the daily death data from the states, they are just struggling to even report it on a daily basis. So we're seeing many states not able to report on days, and then they report 2 days of data the next day. So we're seeing the seesaw in the data, and that's really because they're overwhelmed. And I think right now, most of the energy is going into trying to plan for the surge in the hospital system, finding masks, finding PPE, looking for how they can increase bed capacity, ventilator capacity. So I don't think there's much reporting or attention at all on those issues at this point, or at least that we have seen. The other thing to note is that because of variability in testing practice, lack of tests, we don't really use or give much credence to the case numbers. Because we know, for example, locally here, there was almost no testing capacity at the beginning. And as the testing capacity ramps up, that can overlay and obscure the background epidemiological trend. The death patterns seem better, although we're now getting results in showing that there may be nursing home deaths that have been missed. The more headline-grabbing results are from Europe, where France just announced 1,000 extra deaths that they had missed in nursing homes. But I think there is concern that there might be a little bit of undercounting, even of death, of early on in some states in nursing home facilities. But getting an age-sex breakdown has been hard in most states for deaths and cases and admissions. So I don't think the socioeconomic status or race ethnicity breakdown is going to be quickly forthcoming.
So a quick question: when we are the peak of United States, maybe.
Well, we update it every day on our website. The COVID-19 at IHME website at healthdata.org. We're currently have the peak at around about the 16th of April. Now, I think for tomorrow's update, because we've been doing this out of sample predictive validity testing, where we hold out the data and see how the models have done in predicting the future. That may shift around by a day or two, but basically mid-April is the peak.
Thank you.
Other questions?
So I had a question. This is Jayhun from Texas A&M University. I'm in the same department as Thomas, Industrial and Systems Engineering. So I had two questions actually. One is your projections in the website report full social distancing. I was wondering what that really means in terms of what is full social distancing. Usually the models I see are 50% reduction in interactions, 175% reduction in interactions. So is that a best case scenario you're reporting there, in a sense?
No, the full social distancing is referring to the legal mandates of school closures, non-essential business closures, and a stay-at-home order.
Okay.
So we are, and just to be really clear, we are not using a transmission dynamics model, an SIER model. Those are super sensitive to assumptions that you have to use. And that's why they're all over the place. And we are fitting a statistical model to the observed cumulative death trends around the world, and relating that, in a regression essentially, to these legally mandated social distancing measures. So we're letting the data tell us the relationship. I think it may be possible to get a relative measure of the impact of school, non-essential business, and stay-at-home orders by their relative importance by looking at the cell phone mobility data that's now out there and circulating a little bit. What we see in that data, what little we've been shared with us, is that even before the legal mandates, in some places like here in Washington, people quite substantially changed their behavior as the news of deaths started to come in the media. And so I think there's also this issue of, voluntary social distancing in some settings, even before legally required.
We have one question from chat. Thank you. This is from Monica Aswani, and she asks, there's a significant variation across the state Department of Health websites with respect to the availability and content of data. For example, cases by age and sex, geographical level outcomes like hospitalizations and deaths are presented, and et cetera. The question is, how do you think this variation in data will impact containment efforts, if at all?
Great question. I think right now we're, nobody's really doing containment. We're obviously gone to the broad-based social distancing strategy to try to get the epidemic under control, at least for the first wave. I think as we transition out of that at some point, then containment becomes enormously important. Otherwise, we'll have a resurgence or a second wave. And I think there's a lot of challenges there. There's some data challenges, and then there's just actually the logistics of broad-based testing. Right now, with PCR testing that takes 3 to 5 days to get a result, that's not really an effective way to screen, contact trace, and quarantine because the potential for transmission prior to the test results is far too great. So there's some, practical things about scaling test capacity, speeding up the turnaround time, minimizing healthcare worker involvement in that testing, since that has its own issues around exposure. And good data is going to be absolutely essential in that second, later phase. I think right now, since we've adopted a mass social distancing strategy, the data is important for the planners in hospitals, so that we try to keep track of if these models or other forecast models are way off and people get the surge wrong, but probably don't matter acutely for other than that.
Thank you. Maybe I'll squeeze in one of my questions then quickly. So you mentioned if we're looking at the other side of the curve and the resource demands for ICU beds is maybe going to stretch longer. Have you seen any innovations or do you know of any places that are looking at setting up temporary ICUs, basics needs to make it an ICU quality room? Can we be Have you seen any great innovations in that realm?
I think our own hospital system here has been able to scale up ICU beds with a bunch of innovative strategies. In terms of, and repurposing PACU and, surgical suite ventilators as an example, I think, I don't know about the temporary facilities. I haven't really got any insight into that as to how they're faring on that front. I think the big question that, especially as we try to work, and I just have to jump on to call with WHO, but as we try to do the same sort of forecast for the rest of the world, particularly the developing world, one of the big questions that's emerging in a setting where it's not credible to scale ICU beds, how much benefit and how important is the delivery of oxygen to the moderately ill to reduce progression to severe illness? And has that become the main strategy for, let's say, sub-Saharan Africa, in addition to maybe some form of social distancing, although that is much debated right now, I guess, in low-income settings.
Thank you very much.
Right.
I know you need to leave here in a moment, and so I want to thank you very much for your time. And we can follow up with any additional questions. Can continue. So thanks again, Dr. Murray, for joining us.
Thanks for
Yes.
your interest. Cheers. Bye bye.
Okay. Thanks. Bye. Great. Okay. So our next distinguished speaker here we have is Dr. Micah Ensley. Is Dr. Ensley ready to take the stage here?
Yes, Tom. Hi.
Great. Thank you. Hi. Hello. Thank you for joining us. And I'll get your slides ready whenever you are.
Terrific. So I have a number of different hats. Today, the hat I'm wearing is as the chair of the Government Outreach Committee for the Human Factors and Ergonomics Society. And what I'm going to present is some work that some of our members have just completed. We had the task of putting together very rapidly information on how human factors and ergonomics applies to the COVID response and what we can do to help in those efforts. And I'm going to give you a quick overview of that. Go ahead and bring up the first slide, please. Go to the next one. There you go. So the previous speakers have done a really good job of framing the problem in terms of the kinds of challenges that people are having in addressing this current emergency. We find that our staff members and healthcare workers are having to very quickly learn new procedures. Someone who may have been a dermatologist yesterday may suddenly be pressed into service to help in an ICU, for example. Nurses are having to quickly learn very new kinds of procedures for PPEs and other types of procedures as they get rolled out. Rapidly changing information. We have reported that hospital settings are struggling with lots of new procedures just being ported through email, and it's very hard to find what's the current procedure, what's really going on as they're trying to make these very tough decisions. We're seeing lots of increases in workload and stress as these healthcare professionals are having to work very long shifts. They're having to deal with critically ill patients. They have a lot of new work to do to try and screen people, to reallocate people and do very rapid cross-training across new departments, working on who needs testing, how to get those test procedures expedited. They're having to don and doff PPE much more frequently than they're used to and do a lot of teamwork in PPEs that they're not used to. They can do things like just obscure who they're talking to. They're probably working with teammates they're not even used to working with. So lots of new challenges there. And lots of challenges in communicating rapidly changing procedures and information, both within healthcare settings and externally to the general populace. And we're seeing some significant challenges there. Next slide. So what we developed were 4 basic documents. I have sent these to Tom Ferris. He can share them with the group members who are interested in them that give a lot of details. I'm not going to cover everything in detail here, but just give you a flavor for what's in there. A lot of these are reference to areas where there are guidelines and training materials to help protect healthcare workers, helping them with team performance when they're operating in PPEs and in cleaning and reuse of PPEs. We have information available on that. There's obviously a lot of areas where human factors and ergonomic specialists can help with developing and evaluating checklists and tools. And this is important. One of the things we're seeing right now is a rush to try and meet the immediate need. New ventilators are being designed and developed very rapidly. We see a lot of these online. We're not seeing necessarily that any usability assessment has been done. And I think the feeling out there is, look, we don't have time for all of that. We've got to rush these into production. These are needed very quickly. And that's certainly understandable. But on the other hand, if they're not usable, we're going to see a lot of deaths on the backside because people are going to be making a lot of mistakes with them. I just recently looked online at the plethora of design guidance on people making at-home masks. And I can tell you that many of those, first of all, it's very difficult to tell which one you should be using. Secondly, the instructions are incomprehensible for some of these things. And so we have, general lay people who are good seamstresses and want to do right and help make masks for healthcare professionals or for their families that are struggling to even understand how to do them properly. So just a little bit of work in helping with usability and design, I think, would produce some great benefits on the outset, on the outside in terms of people actually being able to follow through on these. Next slide. We also have a lot of people who are working in areas like workflow and process design. We're having to do, very rapid setup of new facilities for treating COVID patients or for others, and they need to be able to do things like have good monitoring and viewability of those patients so that the nurses can do their job in taking care of them. There are some real challenges with online communication. I think I already mentioned that hospitals are sort of getting overwhelmed with this, everything getting ported through the email system. A little bit of work, I think, by people in this group, if we've got some good computer scientists here who can team with some of our human factors people to develop some more effective communication flows so that people always know what's the latest and greatest and what's changed, that would help significantly. And then just other sorts of human factors efforts going on with layout, equipment, and processes to reduce healthcare worker injury and so forth. So there's some of those kinds of efforts that are available. Next slide, please. We also have a number of recommendations associated with combating stress, fatigue, and burnout. A number of the previous speakers talked about the long hours that people are having and the significant stress that they're under. Here are some good initiatives that, and the references are all supported here, that you can look at for improving healthcare resiliency and performance during the pandemic, for helping to quantify healthcare worker fatigue and burnout, tools to help with implementation and evaluation of initiatives to help reduce fatigue. There's a lot of data there that can be used. One of the earlier speakers talked about changing shift schedules, a lot of data on shift schedules and how we can minimize fatigue through shift schedules, for example. So a lot of data there to help. Design and deployment of health information technology. One of the big challenges that people have right now that's gotten repeated citations in the press are the real challenges with the electronic health records. They don't support good information sharing that is needed for real-time decision-making. I'm part of another initiative with the University of Wisconsin that has redesigned the electronic health record using user-centered design principles to maximize situation awareness for the physician and for the nurses and healthcare team so that they can actually use electronic health records as a decision support tool. These sorts of initiatives are available. It's going to be longer to get things like that into practice. But I think that's something we need to be doing in the long term. Next slide. There's another set of recommendations on communications. We certainly know a lot about how to communicate effectively in terms of presentation of the information. I think it's worth looking and realizing that a lot of these messages are going out to people who have low literacy rates, either because English is not their first language or because they are not that literate to begin with. So just designing clear messaging. There's a lot of data on that, using graphical depictions to augment that. One of my key issues that I'm very concerned about, my specialty area is in situation awareness, how to design and present information effectively. And that's primarily been directed at people in professional positions, things like pilots, air traffic controllers, physicians, military commanders, and so forth. What we're looking at now, though, is a lot of this information is actually flowing to the general public. And we have a huge misinformation crisis in the general public. So just as qualified experts are providing good recommendations, they're getting a lot of data from people who are trying to sell things that aren't well-founded, or people who are telling them, oh, it's no big deal, it's just like the flu. So how people interpret that information is not the same as we see in professionals, in professional organizations. They actually interpret the information based on their own pre-existing mental models and biases, and they may be neglecting. And we're seeing somewhere in the neighborhood of 10 to 20% of people are simply ignoring good advice about what they should be doing because they don't believe that that the COVID crisis is real. And so we have to look at ways of actually combating misinformation in the public sphere, as well as trying to communicate effectively within the professional sphere. And there are a lot of good information on how we can help address this through doing things like, for example, one thing is not repeating false information. What we tend to do is to say, you know, this is a myth, and every time we say what that myth is, we actually reinforce the myth. Where what we really should be doing is just focusing on the right information and not reinforcing the wrong information accidentally by repeating it. So there are a lot of things here that we can do, and some good information on how to do that to try and improve our communication problem. Next slide. And then similarly, the fourth document that we've developed is in applying human factors ergonomics to disaster response. There has been a lot of work over the last 20 years in the disaster response area. There are guidelines for training and team decision-making for emergency responders, for computer-supported cooperative work, for developing situation awareness-oriented dashboards to help form information. And one of the real challenges that we see in emergency scenarios, and the COVID response certainly falls in there, is what happens is that people get focused on what's going on within their organization. And we see reduced situation awareness and information sharing across organizations and across teams. And that's where a lot of information falls between the gaps, particularly when our information systems are not well set up for information sharing across organizations. So there's a huge gap there in trying to better share information across organizations who are involved in the disaster response, either within healthcare organizations or in the logistics support system that's needed to keep things moving in support of that. We see a lot of confusion right now with where are the ventilators, what's their operational status, who needs them, where are the PPEs, how can we get them? We see lots of confusion going on in those arenas. We're looking at logistics systems where the National Guard has been called out to help with things like stocking grocery stores and keeping social order. So there's a broader set of emergency response problems that are going on that are also going to have a large effect on human life. So a lot of good recommendations here on what we can be doing. And I will stop there. The details of all of these, Tom can share those documents with you.
Thanks very much, Dr. Ensley. And we have, of course, references here. And I just put in the chat that I can share those with all. I'm actually downloading, and I think I can share them even right through the chat right now. So I'm going to try to do that. But if are there any questions for Dr. Ensley, please?
I have a question for you, Dr. Peter. I think the major limiting factor will not be the ventilator or the room to treat patients. It will be the team. We have a limited number of critical care physicians pulmonologists, surgeons, anesthesiologists in the country. If you look carefully at the number of physicians going into critical care medicine doing fellowship is kind of flat and or maybe decreasing over the last few years for multiple reasons, but one of them is the quality of lifestyle. So the question is, I think, yes, ventilator may be an issue during the surge, but I think the main issue is the long term. You know, when you flatten the curve, as you said, you still have a lot of patients sick. And what can we do to increase the number of people available to treat this patient, healthcare worker?
Yes, that's certainly a significant concern, and I don't doubt that you're right. You know, long-term, getting more people into healthcare and getting them trained up, that's a longer-term problem. What we can do I think, much more quickly is look at how do we make best utilization of the people that we have in the system. And there's certainly a lot of information and guidelines on how we improve team coordination and communication and effectiveness. I've done a lot of work on team situation awareness and how we improve information sharing and understanding of the information that you're sharing across the team. And I'd be happy to forward that document as well, because there's a lot of that's been applied in the healthcare industry for things like team training scenarios that I think would help a lot in a scenario like this where we have to do very rapid cross-training of people.
Thank you.
And I am still working on sharing those documents, but I'll get them there. I had one comment also from Dr. Krista Flitch, who has since needed to leave for another meeting, but he mentions that at Penn State, they're doing significant CDS, situation awareness, and tracking through the EMR, but it's changing daily. And so he says, true PDCA, I'm not sure what that means, but at least we're hearing, you know, other parts of the country who are integrating these into their EHRs or EMR. Okay. Well, if there are any other questions for Dr. Ensley, I will thank her once again. Thank you very much. I'm going to share I have to change the settings on the Zoom meeting in order to share these documents, but I'm working on that. So thanks again, Dr. Ensley, and I believe we'll continue now with Dr. Hui Yang, if you're ready, Hui, and we can talk about your project.
Yes.
Great. So, thanks, Dr. Yang. I'll turn it over to you, and you can tell me I can advance slides and all.
Hello, everyone. First, thank Tom and Lauren and the leadership team for quickly putting together the conference call for the COVID-19 response. My name is Hui Yang. I served as site director for Penn State CHOT since last August. And today I'm going to share some of our ideas for the spread of the virus spread simulation and analytics. It has been a great journey to work with an excellent group of researchers in CHOT and since then. So if we want to look at the pandemics in the past, and we don't just have this COVID-19 in a few years, and the pandemics actually keep coming back after a few years. As you may see from this slide, the mother of all pandemics is 1918 virus, flu virus. And it caused like 50 million deaths worldwide and 675,000 in the United States. So are we ready for those pandemics? Like Bill Gates mentioned that the preparedness of the pandemics like 5 years ago. And we may be ready, we may not be. In the beginning of March, we may not be, and we may not even realize the flu virus caused a pandemic that is totally different from the flu virus caused the seasonal flu. And just like the cat and the tiger, both of them, they are from the cat family, but they are different. In the past 100 years, most of the pandemics, they are caused by type A flu virus. And now we have coronavirus. Okay, and this is a picture from Jeffrey capturing a killer virus from January 2005, Scientific America. And what kind of action can we take? Please advance. And in 1918, can you please advance the slide? Yes, in 1918, we don't have many antivirus or vaccine available for this virus. And we can only take non-pharmaceutical interventions like isolations, quarantine. We also have school closures and a good personal hygiene and the use of disinfectants and face masks. Those are all the actions. Social distancing, most importantly. Those are the non-pharmaceutical. Those are called non-pharmaceutical interventions. But how are those non-pharmaceutical interventions interact with the spread of the disease? And also, how do they help control the disease? Please, next slide, please. So the virus actually has huge impact on the healthcare systems. And 2 days ago, I was talking with doctors. They are in the front lines, and Dr. Chris DeFlich and others. And the first question they are talking about is to prevent the hot areas. That is, we need to really prevent the outbreaks in the hospital and the communities. So hospital has become a really hot area, like in New York and in many other places, in China, in Italy. So only by keeping the hospital safe, then we can really deliver high quality care to those patients. And also the last one is protect the healthcare professionals. That's the PPE equipment that we have. And at Penn State, we have this mask efforts. And in CHOT, we have CHOT scholars also involved in the mask efforts, MASC. So CHOT scholars like Fahad Imani is working with the 3D printing team to print the critical parts for the ventilators and also produce the quality assurance, quality control documents for those ventilators. So those are some of the efforts that happened in Penn State to produce PPE equipment for healthcare workers in Hershey and in other healthcare systems. But most importantly, for CHOT, how can we help redesign the process flow to improve the healthcare delivery to patients? And one example is in Hershey Medical Center. We actually had a tent outside of the hospital to do the triage before all the ill patients get into the building. And that's the first step, and also the testing facilities we have. We are taking a very much different approach and a very cautious approach at the Penn State Hershey Medical Center, that taking the experience and the examples from other places and also from the lessons learned from New York and other states. Please, next one. And when we come to the data analytics or the computational modeling, the first question we ask is whether the data, having errors, have errors, whether they are integral enough. So data integrity issues. So this is the animation. If you click on the animation, you will be able to see the, so in the very beginning, although the data might have errors, right, from places, you might have, the testing may not be enough to get all the confirmed cases. But the genetic sequence, they don't lie.
So I'm on a business phone conference.
The genetic sequence, they actually don't lie. And as you can see from this animation, the original genetic sequence for COVID-19, this is available in the nextstrand.org. Okay, and if you see this animation, you will be able to see how many mutations, how many transmissions we have in the COVID-19 virus. So that's why this makes it very difficult for us to develop the vaccine. But at the same time, it provides another set of huge data for us to analyze the transmission dynamics of the COVID-19 virus. Yeah, if you come to the back of the end of the animation, you will be able to see how many variations of the genomic structures we have only for the COVID-19 virus. And this set of data genomic structures, they are open to the public for the data analytics and study for the research on the virus spreading dynamics across the globe. Next one, please. So in Penn State Charter, we have some ideas to develop the models, and this is the left side is human movement patterns in a city area by Zhengbang Chen in the Penn State Charter. And this model is actually a mechanics model that based on the physics, we're trying to simulate how humans move in a city. And then we can see how flu, if a proportion of the people, they have virus, then how does it got propagate and spread to the whole population in this city. And we can simulate a large number of initial population. And then with as we are doing the social distancing, we can reduce the number of population outside to doing for the interaction and the movement in the park in different places. So this simulation model provides a high level of flexibility for us to do experiments, because in the real world, if we are doing experiments, sometimes we have practical and ethical limitations. But simulation models help us to test the policies we could use to optimally control and contain this virus spread, and also test different strategies. And then the right side is a data-driven model. Data-driven model, as you can see, we have actually geospatial data, but geospatial data also change over time. So that's why we call it the spatial temporal dynamics of the virus spreading. So it requires us to gather the data in different areas, but those data are widely available from New York Times. If you search GitHub, the COVID-19 data, you will see from New York Times, from Johns Hopkins, and from China, and all kinds of data are available for us to study the spatial temporal transmission dynamics, and also help us to predict the virus spread around the globe. So two set of models, mechanistic and statistic models, can be used. Next one. And how, now let me share some ideas. And CHOT, we have an excellent team of interdisciplinary researchers. And yesterday when Lauren asked me for slides, I was going through all the products and outcomes we produced in CHOT website. And I see a lot of projects as CHOT insights, like the first one, integration of genomic data for precision health decision support. So there are a large amount of genomic data for us to study the transition dynamics and the spread dynamics of the virus through the genomic structures and mutations. And there are also some other projects that we did in the past. Those projects can be used and can be reused for the to support the fight against the COVID-19. And second one, telemedicine. I highlight some of the keywords: the telehealth systems and sensing systems for personalized telehealth wellness. And those telemedicine can really, if patient does not have very severe symptoms, if we are going to have those patients at home, and how can we deliver care to those patients? The telehealth and telemedicine systems are very critical. And we have results from the past, and now we can put teams together to explore those ideas. Although those ideas are for different kind of disease, but some of the methodology and the ideas can be translated to fight a new kind of pandemic. And also, if we have patients with different levels of the symptoms, and some of them, they are very severe, and some of them, they have very light symptoms. And if we are doing the tele-doctor, or how do we match those patients with the physicians available? Because now we see we have a lot of shortage of the staff and physicians, but how do we effectively allocate the resource and match the physicians and patients? So those are some of the existing projects. And also machine learning, AI. Can we leverage the results from previous project for the evidence-based practice, resource allocation, risk prediction, and system analytics? So those are the previous projects to optimize the clinical workflow and patient care. And I think Dr. Petit mentioned the critical care, doctors, a shortage in the critical care. So we had the AI-based critical care scoring systems. We can stratify the different levels of the patients and then leverage the resource we have to maximize the usage of the resource we have to treat the patients. And also the human factors and stress and social well-being and mental health. And one of the CHOT scholars, actually, he has already graduated, but he reached back to me. He's saying he has already organized a large set of data on from Twitter about the people tweet about the COVID-19. As we can see from the beginning of the March to the end of the March, people has different reactions now, different feelings about the COVID-19 and some a higher mental workload and stress. And how can we analyze the social media for social well-being and mental health? So those are some of the ideas and some of the methodologies, and that we have studied before. Now, how do we translate those to the fight with against the COVID-19? Those are some of the ideas. Next one. Although we are working from home, and I would like to quote from the Roosevelt, do what you can with what you have, wherever you are, and then we can contribute. Although we have different expertise, some of us may be doing data analytics, others on the front line, and others with system engineering expertise. But do what we can and with what we have and where we are, and we can collaborate and together in the CHOT to fight this COVID-19 crisis. Thank you. This is the end of my talk.
Thank you very much, Dr. Yang. Because we're pressed for time, we're over our scheduled time, but actually as good as we tend to ever do with these. I may move on now to Dr. Cash and have her present her work. However, I want to make it clear to the group, we're going to stay on here with the CHOT folks as long as there's discussion to be had. So if there are follow-up questions that we can have after Dr. Cash with any of our remaining guests, by all means, we can ask them then, and we'll go through at that point. But thanks again, Dr. Yang. And if Dr. Cash is ready, we can have her talk a little bit about her project directions. And Dr. Cash, we don't have sound from you. Okay. I see she is connecting to audio. While we're hoping that her system comes back online, I just want to point attention to the Zoom group chat here. So I can't on the fly figure out how to share all of those documents via the chat. So what I did is I put them in a shared Google Drive account, which should be open to anybody with this link. And so it's this https drive.google that ends in the word sharing. Copy that, put it in a web browser, and you should have access to download those Human Factors and Ergonomics Society documents. And again, that's what Dr. Micah Ensley was referring to in the response from that community that we've started to organize. And it details a lot of the aspects that she spoke about.
And Tom, I just heard from Beta, and she's having some technical difficulties. So she mentioned that we can go ahead and move on.
Okay. Okay. Mm-hmm. Good enough. Yeah, if she can join, we can add it in later. And again, I know we're over our scheduled time, but we'll continue talking here. Those who need to leave, this will remain recorded, and I will, especially if you have shared your contact information. Let me just remind about that again. If you haven't done, this yet, please do let Lauren or I know, or via the Zoom chat, who you are. When we have your email info, we can email out the recording link. All right, so I am going to move along here unless Dr. Cash interrupts me to talk about some of the...
Hi, Tom.
Oh, great. Hello, Dr. Cash, please.
Yes, I changed phones from cell phone to a regular phone, but I don't know. This has been challenging, I guess, but I'll make this short. I know we're over time. Just if you wanted to know more about the rapid grant application we put in, we have a multidisciplinary team of 2 faculty members from the School of Public Health at Texas A&M. We have one from the Department of Recreation, Parks, and Tourism Science from Texas A&M. From Boston University, we have faculty collaborating who's from the School of Hospitality Administration. And then finally from Florida State University, a colleague who's a professor of hospitality management. And really the proposed project is to test our preliminary assumptions and observations concerning the hospital patient spillover into hotel facilities during this COVID-19 outbreak in major metropolitan areas. So we will be studying several metropolitan areas. And some of the research questions have to do with how do hospitals in various overcapacity situations during this pandemic collaborate with hotels to use their facility to accommodate patients. And mostly we were interested in accommodating patients of various risk groups, but it looks like we're also needing to focus on people who need to self-isolate. And more we see that healthcare workers decide not to go home and self-isolate. So those are added groups that we would need to study as well. At the end, it's very much a solution, policy, and practice-based project with hopefully policy and practice recommendations for the next, hopefully not pandemic. So that's a quick overview of this rapid application. Thank you.
Thank you very much, Dr. Cash. Any questions for Dr. Cash on that one, on this work? Okay. So now we'll transition then into just talking a little more generally, the conversation around, we want to ultimately form some working groups here so we can start putting pen to paper, fingers to keys, and building some statements. I do want to mention we are a center that has resources to conduct research, and we are also at a key point in our annual cycle where we propose and discuss and eventually approve what will become our next research cycle for the coming year. And so by all means, where it's appropriate to do so, we want to support COVID response things with our CHOT funding. Of course, these are, we can go through the normal procedure here where we will present them to our industry and there will be voting. This, which was originally our spring meeting time, is not the spring meeting. We will have that when we can get a handle on things, when the world starts to open back up. We're aiming for sometime in May, hopefully. But I also want to point out external funding opportunities. We've already heard from Dr. Yang and Dr. Cash about the NSF Rapid opportunities. This is a National Science Foundation model that's designed around we're not going to, spend months writing this thing and then having months for it to review before it happens. It's a direct submission, usually to program managers who have the power to make quick decisions. And I know, at least in the case of what was presented here, these are already turned around and already ready to go. And so this is a great mechanism for the next year. Here's what we want to do: 5-page research paper, 5-page proposal. I have CHOT members know that we have some shared documents where we're compiling lists of these funding opportunities, and I have that shared document. I just heard from Lauren that all of these things we're talking about we'll share with you. We'll try to put them all in one email, send them out to everybody, but there are links to those who are interested in adding to this list or seeing some of the data that we've already been compiling, these are opportunities that are, you know, in some cases coming up very soon or already, you can see already passed in some cases. But lots and lots of, it's too many to really even discuss and bring up here, but you'll see several links on that page that can lead to additional lists of here's COVID specific sorts of response mechanisms. So I also want to point out CHOT as a center, and this includes those who are current members, but I wish on this list we had more comprehensive for everybody on the call, because we'd like to consider everybody here as a collaborator with us in this. But just to note some of our scientific expertise, we also have lists of these and some of the skills, the unique skills, the useful skills that our researchers and our industry members have at their disposal for conducting research on this area. We heard a lot of things today about human issues. Of course, that's what I think about. That's my area. But we heard a lot of things with data, a lot of things with modeling, a lot of things with decision support, resource management. And so these fit into the expertise of our researchers, but it's also good to remember that, you know, we have these skill sets. These are at our disposal for applying here. And finally, as we've talked today, there were thousands of ideas thrown around very quickly, but I want to point out we do also have a shared document where we have already been discussing several potential ideas among our center members. I've just summarized this. This came from where the state of this document was last night, and I have seen that there's even additional additions to it. So thank you very much for all that, everybody who contributed. This isn't meant to be read, but again, we can share any of these links. But I just want to point out the things we had talked about earlier in case this now resonates a little more. Designing for infectious space, and this includes in care settings where we have you know, infected people in the same space as non-infected people who would like to stay non-infected. We have healthcare workers who are moving between these communities. We have need for isolated spaces. That is a new demand in a lot of these settings. And we also can talk about outside of the healthcare setting, essential work activities where that must continue, and especially with regard to this response, think of the resources that are being produced: masks, personal protective equipment, ventilators, etc. I know there's a lot of improvisation in the production of those, but we need to keep things moving in a world where there will be infected people, or there will be, you know, exposure to the risk of infection, and so designing for that. Designing for communications. This is actually, Dr. Ensley talked a lot about this, at least from the human factors perspective, but the need to be able to communicate both in the sense of we want information in a common place. We heard a lot of people talk about there are all these different forms, or all these different servers for how people are communicating. It's all distributed, and in order to coordinate things, having a centralized, common, and especially a resource that's full of true information and devoid of misinformation will be very useful. Also, in ways that we communicate, or we can provide guidance in communicating to target populations. And so things like she had mentioned, the low literacy groups, maybe those who don't put credence in the message that's coming to them, that they need to be socially distancing, that they need to adopt new behavior that will, you know, help stem the spread.
This is Craig Scott.
Hi, Craig. Yes.
Can I interview with a question? While we still got as many people on as we have.
Yes, please.
I'd like to know if we could have invite people to share their thoughts about the post-pandemic world and the needs of healthcare organizations. What we're looking at now are the things that we pretty much could have predicted almost before the pandemic. I'd like to know if any ideas occurred to our participants as to what kinds of new research that was not anticipatable should organizations be thinking about conducting, and should CHOT be thinking about conducting, now that we're operating in a post-pandemic world where pandemics, we all know, will reoccur. What do they need to do differently? And how can CHOT help in a research status?
Yes, I'd like to echo that. That's an important point too. And yes, while we need response now, this is, we've heard from several of the experts also, this isn't going to go away in a few months. It's going to be a continued thing. And so how can we be, and I have this listed as resilience, a resilient healthcare system, something that we can learn from what we're doing now and be better prepared in the future. And I think this almost applies to everything we're talking about today. Also, how is this going to be leveraged for future response?
Jamie, are you with us, and do you want to say anything about how the landscape may have changed in the last 3 months for hospital organizations? Or anyone, if Jamie is not with us.
I think this is Hui Yang. If I can chime in, in the very beginning, like in the beginning of March, and we have a very nice period of time that we can start early preparing for the pandemic. But we don't have awareness of the situation at that time. And some people even think it's just a flu, right? But it's a flu pandemic. It's a COVID-19 pandemic. Now we realize, more and more people realize. And in the very beginning, healthcare system, they are not well prepared, if I can say in that way. Because if the COVID-19 patient come to the healthcare system, and the healthcare workers, they are not protected in the way they should be. So that's why hospital suddenly becomes an outbreak area, a hot area for outbreak. Then infect more and more people. So I think now people really have treated this very seriously, and now more and more PPE equipment are used. And but then we have a shortage of the supply. So as the situation is moving forward, and I think now we are gearing up the production, and even in the university we're using 3D printers to print all kinds of PPE equipment. So healthcare system are changing, and but you bring a very good point on how do we do the future preparation, because many people sounded the alarm 5 years ago, and how do we prepare for the next pandemic? And now it really comes, and we are still not well prepared. So as a whole, like here, we're the CHOT team, and how do we think, as Scott just suggested, and for the future, and we have produced a lot of research results as in the website, a lot of CHOT insights, and how do we leverage those results, and maybe think about how do we build a more resilient and as Tom just mentioned, and be better prepared for the next pandemic, and also how do we tackle the situation right now as it is changing and dynamically changing every day. Thank you. That's just my 2 cents.
Thanks, Dr. Yang. I also want to point out, I know in reading through the shared, document here, there were several IAB members, industry members, who had also contributed. All right, what happens next? We got to learn from this, after we get over this, the immediate need to just do whatever we can every day. We want to learn from this and do better next time. So I do think that's a major area where we can contribute, is that future preparedness and being ready. Yes.
This is Chris Johnson. I think that another big area that a number of the healthcare systems are dealing with is a rapid adoption of new technologies and new ways of doing things much more rapidly than they would normally do. And so I think that's a prime area of studies because, so in 1 week, CMS changes the telehealth rules. Next week, CMS changes credentialing requirements for telehealth. And so literally in 2 weeks, the whole telehealth world changed. So how do you as a healthcare organization or a hospital, gear yourself up fast enough in order to take advantage of this remote patient monitoring and telehealth is an issue because that's much faster than at least I've ever seen happen in my limited time on this earth. So I think that's going to be an issue that all health systems are trying to deal with, not just in telehealth, but any kind of technology. How do you rapidly adopt these new techniques or ways of doing things, going forward?
Thanks, Chris. That's a great point. Thank you. Welcome any other comments or ideas, elaboration on anything we talked about today. And again, I will make sure people are able to view and contribute to the response shared document. The goal is, of course, not to just list as many ideas as we can think of, but then coalesce on some that we can focus in on and develop. And I'm imagining, a handful of these, if not several, could come from our groups. So those of you who are already expressing, I think this is a big problem. And if you have a personal interest in those problems, we may say, hey, can you be a point of contact? And we can coordinate those workforces with each of you. Go ahead and jump in if there's any other thoughts from the crowd, but I will just continue going through this list here and quickly summarizing what I had seen in our current discussions. Resource shortages are, of course, big on everyone's mind. Personal protective equipment, masks, ventilators, etc. Also, space, so ICUs. And also, of course, personnel are all shortages here. So we've talked about alternative productions. Chris just mentioned, Chris Johnson just talked about how there's a lot of new sources of these technologies coming to market. When people are sewing masks at home, that is fantastic, but we want to make sure that those are useful masks and that they're being worn appropriately. And so looking at the production issues, the supply chain. We heard Grace Simrel talk about how all of the supply chains are being disrupted. That's obvious. And so those of us with, industrial engineering background, supply chain research could be addressing some of those issues. We talked at length about future preparedness. I won't go into more on that now. I think that's going to be a clear area that we can contribute. Decision support is something that is in need, and especially, and I've heard this for feedback from several people in industry side, they're making very difficult decisions with not the clearest guidance. And when I say difficult decisions, I mean things like who gets a ventilator and who doesn't. And that's a reality, a harsh reality, where there needs to be some reasoning behind when we can't give something to everybody who's our priority. And I had heard that support, so a tool, an algorithm, something that can help guide these decisions, make these highly emotional decisions a little more objective. As cruel as that sounds, I think it's useful and necessary. We talked a lot about telehealth and remote patient monitoring. I've already had a telehealth meeting with my own doctor, just as my wellness exam. It was the first time for me. It went better than expected, but we can do quite a bit in the virtual realm to support communication with healthcare providers, to support the communication of information, instructions for how to, how people can treat themselves or how they can, protect themselves to be less likely to get the disease. CHOT in the past has done quite a bit in the realm of telehealth and remote patient monitoring technologies, as far as how do we address our more difficult to reach patient populations, which is a lot of our country, those in rural areas, or those with social factors, demographic, economic situations that make it more difficult for them to travel to see healthcare providers. That's of course going to be increasingly an issue now. We heard quite a bit from folks that are emphasizing the problems with our healthcare workers. So the burnout, the fatigue, and the stress that they are facing is higher than normal, and it is longer than normal. And so some of these design possibilities, can we look at new ways to have, shifts? I heard one of our experts talking about shift management, designing new shifts to minimize these. But we also have researchers, across our center, in our universities, who do excellent work in the theoretical aspects of what's causing these fatigue, and how can we come up with tools to address it, help people self-assess when they're maybe getting dangerously fatigued, and find mitigations for that. And then, and this is not last, but just on this list here, again, I think the healthcare workforce management, we have a lot of experts here on the call who are in the management of healthcare systems in some form, and we have to care for the people who are caring for everyone in that sense. And so, and I know Theo Edmonds had contributed quite a bit on the future of work, and that kind of ties back into one of the NSF projects we can target, one of the outlets we can target. The future of how this is going to be done, well, the near future is going to look a lot like what we're seeing today, we think, or worse. And so how can we be prepared for that and minimize the amount of problems that we can face in the near future? Would anybody like to elaborate on any of these points? I'd be very happy to turn over. Okay, let me return to the chat.
Let me say something, Tom.
Yes, please.
I think this is the time when, as I've said on a number of occasions and shown slides, it's time to think out of the box. We're facing a new situation. We need to get, I was hoping we'd get more of a discussion today, but hospitals need to be different in the future. For example, I was just sitting here trying to do it myself, thinking out of the box. There may be a way to make it so that beds in ICUs can be shielded, not from the practitioners in the room, but shielded so they're still accessible in some ways, much like is done in laboratories with dangerous materials behind glass that hands can go in. Maybe there's a way to do negative air pressure containment of the actual bed so that anything that goes into that goes out through the wall and the air is not completely recirculating in that room and out into the hall. I'm just trying to think out of the box. What do hospitals need to do differently in organizations planning for future events of this type of communicable pandemic situation, whether it's viral or bacterial or biological? That's what I think CHOT can help with. That type of thing.
Yes, I agree. I agree.
Different work than we've been doing.
Yeah. I have heard I'm not in the world of hospital design, but in reading online, this is something that I had seen. That's why I asked about it to Dr. Murray, was can we convert current spaces, what makes it ready to handle an infectious patient and their needs? And the positive pressure aspects, that it's news to me, but that seems to be something that can be implemented at a surprising level in current hospitals. We're going to turn this into a positive pressure space. But yes, finding solutions that are cost-effective, time-effective, and repeatable, for what we can expect in the future. I think that's a great
The other
place to
question
push
I
us.
have is, we're hearing on television how we lost the month of January in many respects. We lost the month of February in terms of the response. We've lost the month of March. And we have the month of April. Is there data that CHOT researchers maybe should be collecting now, as soon as possible, quick and dirty data that will help decisions be made in May and June and July and beyond? Data that if we don't get it now, we might not get it. I mean, we're all in, many of you are in hospital systems and situations where you could collect some quick and dirty data that if it's not collected in real time, it won't be there. We should be thinking about that as well before another month of opportunity is behind us. That will help us deal with.
Craig, those are great comments. This is Theo. I wanted to add kind of to the really good conversation going on around industrial design and the clinical side of things. Dr. Kelly Pryor has a great comment around the socioeconomic and demographic racial breakdown of this disease. And as we learned from the Federal Reserve at the beginning, who sets monetary policy for our country, as well as from Grace Simrall, who leads local government initiative, because so much of this is happening at the local level. We should not also lose sight of our ability to take the depth of clinical expertise and depth of engineering expertise we have and really rally this moment to provide the contextual social aspects of this too. Because when we look at things like some of the stuff that Grace was talking about, and also that the Fed was talking about in terms of trust as an economic factor, we already know that medical mistrust in the system is very high, and I suspect that we may see it rise even further, which further implicates our ability to impact and perform at future crises like Corona. So I just want to be sure that we level set on this and create an opportunity where we're integrating the depth of skills and knowledge of both context and clinical delivery that our group now has.
Thank you, Theo. Yes. Yeah.
Very good point. This is Hui Yang. I think data are available in different levels. For example, US has consensus data, and which is also is undergoing the connection process. But we have last year's data, and they are readily available in terms of the social economic factors in a particular region. Then we can also have the confirmed cases, deaths, and in each county, each zip code, and also the temperature, humidity, air pollution by regions. So we can study the environmental stability, whether the high temperature and those kind of things, and we impact the coronavirus. And in terms of social economic status or the factors, we have disease factors and income factors, economic factors, and social factors in each county, each zip code. And we also have the COVID-19 data in each county. So how those are correlated, and how do we study those so that we can contribute to the non-pharmaceutical interventions. And in terms of the hospital design, it's a negative pressure, like a ICU unit, because all the air needs to come in, not going out. Positive is going out. And so that's a negative pressure. And also I think the healthcare is increasingly pushing to the end of the patients. And if the patient is at home, how do we see those patients and provide the care? So those are something, not only just we design the hospital, but how do we promote the change to a different healthcare scenario, like the at-home care, and all the push the care to the end users, to the patients, not just get all the patients to a centralized place. So in supply chain, we have distributed supply chain. Manufacturing, we have distributed manufacturing. But healthcare has always been centralized. I mean, we have in CHOT, we have been studying the telehealth systems, telemedicine, and can we further promote stimulate the change of the paradigm shift through CHOT to push the healthcare to the end of to the end users, and we can deliver the pharmaceutical products to the end users, and seeing the end users through the telehealth systems and match them with the doctors, and also instrument the home with sensors so that we can get all the accurate measurement of the patient, right? So you can, especially for the elderly care, assisting living facilities and nursing homes. And if too many people come to those facilities, and then they bring virus and they cause problems, but how do we push the care to the end users? And that's something that I just want to bring to the table for everyone to think about it, and hopefully we have some action plan or the ideas around this arena, and then we can leverage the CHOT and then push this paradigm shift. Thank you.
Thank you, Hui. This reminds me, I wonder if Judah Thornwell, I see Judah's on, and was the person I thought of right away when it was, oh, now what if we have data that's personal data that could be contributed to these issues. So I'll see if he has any comments, but I just did want to say, Hui, what would be really useful, I think, is all of these public data sources in the same folder where we're sharing all of these shared things. Let's see, maybe we can come up with a list of, hey, here's where you can find all of these data. This can kind of help us organize, all right, here's the things we could look at as well, I think.
Sure.
I'd like to suggest another question for consideration of any clinicians that might be on this call and on call every day, or in the hospital or clinic every day. What have you noticed about your organization that needs to be transformed? Ahas, insights that you've gained from being on the front lines. I know there are several of you that have thought about this a lot and think that your organization in some ways is failing you more than in just PPE. If you want to share any of those thoughts, if you have them, this would be a good time to throw those out.
Thomas, this is Judah. Can you hear me?
Yeah.
Yeah, thanks, Judah.
So one of the data points that have been in the news is and Theo was mentioning this, but the relatively massive social impact of what's happening, not only on the frontline workers, but every frontline worker is in a social network. And then everybody who has a loved one who is ill or dying or has died, they're embedded in a social network. And so you're going to have this potential cascade of trauma and grief and depression and compounded by the inability to use traditional methods of face-to-face connection to process that, combined with loss of work for millions of people and so on. So one of the research questions that I think could be interesting is how can we leverage the new data infrastructures, the new rules in terms of data sharing and ability to get data in and out of EHRs, and combine it with this new kind of data in some kind of a meaningful way, but potentially with an emphasis on finding creative ways to deal with really some very simple stuff, but at a massive scale of how do we process, how do we help people process all of these traumatic and sad and difficult changes and losses. So just a thought.
Thank you. Yes, I think I heard a little of that resonated in our earlier speakers as well. So that does seem to be something we could contribute to. Thank you.
So this is Chris again. So what are the next steps, you think, in order for us to move this forward? I mean, should we set up work groups and have work group conversations, or what are we thinking?
Yes, I think it can be an opt-in sort of thing, and we'll coordinate after the call. But what I'd like to do is have points of contact, probably within CHOT members, but doesn't have to be within CHOT, I suppose. And then coordinating groups that can discuss, here are the problems that we care about, coming up with research statements, which can be, anything from a short thing to share amongst us, but then also we can help connect to these external opportunities, that might be appropriate as well. So, I can do everything that I can to provide information, but we'll need our CHOT members to step up and say, I can be the point person for any of these topics. And if we're ready for that, we can move into it. I did have just a couple of other chat-based questions and statements that I should probably read first. Are there any, before I do that, are there any other vocal discussion points we want to cover? Okay, so one point that was made, which a little bit different, but I think it's relevant to some of the conversation around training and can we get the right information to the right people. So Lauren Massengale is a industrial engineering researcher working with us, and she says that now most American children as well as adults have laptops and high-speed internet that are required for remote learning. Can we leverage some of these connections and finding about ways for sustainable long-term public health options? So the same channels that are being used for staying at home education now can also be those we think about for disseminating instructions and encouraging the right behaviors. So I thought that was a great point. And any questions or comments on that? We also have from Brandy and Brandy Kelly Pryor, and Brandy, if you would rather elaborate on this, you're welcome to. But she says something we can't forget in all this research is about the socioeconomic demographic as well as racial and ethnic breakdown. This is critical in every level of understanding of the virus. So who has access to telehealth, who has access to testing kits or ventilators and other equipment, which hospital staff and personnel have access to those PPE, personal protective equipment, social distancing rules and regulations, and many more issues. So wherever there are questions of equity, social equity, dealing with social demographics, racial characteristics, let's consider what might be different or might be additional challenges for certain groups, and remember that as we're moving forward as well. So I thought that was a great point. Thanks, Brandy. I've heard that echoed by a few of us as well. So we're not solving problems for one type of person. We're solving them for many, many different types of people. But some of these, social factors, demographics can help us determine what unique needs are for those groups. Brandy also says, so this may cause for how we think about this may be cause for us to rethink about what we use hospitals for. So along the lines, Craig, of your, this is a think outside the box, sea change sort of opportunity. Many people use the ER as their primary providers. That's not going to be sustainable. Another example is thinking about births happening during this time. And there are critical decisions that individuals giving birth are having to make about who is the one person that may be able to accompany them in the hospital. And some hospitals are turning away support people for fear of contracting the virus. This also resonates with some of the conversations earlier. How can we have people see their loved ones in these settings or have that meaningful interaction? So giving birth is one very traumatic, happy, hopefully, time of life. But there's a lot of issues with just access in general for patients. Hospitals are turning away these people, and so how is COVID-19 impacting birth centers and other alternative birthing practices. And so, yes, so I think this is a general statement of one other area of how COVID is dramatically affecting that area of healthcare. And we can think about those individual sorts of areas as well. Sorry. Are there any other questions or comments, or I can move on to wrapping up here? Okay, so what I think we should do in interest of time is have ourselves cooking on some of these ideas. But what I would like to ask the CHOT membership, and this is everybody, is to have a look at what we will then now distribute, which will be, again, the shared documents, which are lists of our potential research ideas. A lot of this is what we've talked about today won't be on there quite yet, so we'll need to be further developing it. And then I would like, and especially those who are, in the leadership positions, to offer to champion certain efforts, be the point of contact that we can organize groups around. And these groups might, hopefully will include as many of our CHOT network as we can. But if you're open to accepting collaborators from all walks of life who are on this call, I'm sure you could get some valuable input there. And so, or if anybody else has any other thoughts about how we might proceed, I would suggest we follow up on email and we point people towards these written aspects, and we seek volunteers to lead efforts.
This is Hui Yang speaking. I think I can be a facilitator, not not needing an effort.
Sure. Thank you. Yes, and that's what we're looking for as well. We have to be reasonable in where we can focus our time. And so maybe from the talks today, everybody on the call could think of one or two areas that are really interesting and important to you. And please be prepared to, if you say, hey, I'm interested in this and I maybe want to be part of it, then we will want you to be part of it. So, so as you are submitting interest to things, think of it as a soft commitment to helping with them. And we'll appreciate that. Thanks, Hui.
Tom, I'm happy to take on some of the facilitation on the future of work aspects of it, including, burnout. I mean, there's a lot of different things that we could capture under that.
So we can work through that table that we are adding to, and we have the CHOT core mission column. We can also kind of modify and add, okay, here's your point of contact with those. So maybe we return to that document and kind of clean it up and put you there. But thank you, Theo. That's awesome.
I would be pleased if someone in CHOT would think about doing a multi-site survey of frontline clinicians, people who are first responders, while this is all fresh in their minds, while they're under a little bit of stress and maybe shortly after. What insights do you have as to how your organization can improve and build around that? But to assess their now real-time, soon to be looking back, their thinking as to what's not being done right in their organizations. That could be invaluable data if it's more than in a couple of hospitals and a few clinics. I'm thinking 30 of different kinds of hospitals, public, private. We can all go on and on about how broad that survey should be. Somebody needs to do that. Because I think it's not the administrators that necessarily know what needs to change. It's the people that work for them. And it's not just in one institution, it's in many different settings, in many different circumstances and environments. So if somebody could pick up on that, I think that could be invaluable.
Great idea.
Craig, I think the University of Louisville can help to champion that. It's kind of in the core area of what we're already doing. We would need feedback from others to make sure we're getting the right questions and not creating half an hour survey that is kind of capturing everything, because that's going to just not really deliver the benefit that we could have.
Open-ended, I think, would be the best way to go, to get people's thoughts. They're going to be willing to give them, I guarantee you, more than usual.
Yeah, U of L we can take some of the leadership role in that, and if others can help us distribute it and pull in the right questions that we may not already be thinking about.
Well, the questions, and then each of our sites should be able to provide multiple clinical sites, so that we have 4 or 5 dozen sites participating, so that we can generalize these results like we don't usually do.
The only caution that I would give, this is Chris, the only caution I would give is that many healthcare organizations are not necessarily open to their frontline staff discussing these kinds of issues right now. So you have the problem where their directives being written by
That's true, but we're in a new
hospitals.
world and they need to learn, and I think we can help them learn.
Yeah, well, I'm just saying that the organizations themselves might resist that kind of surveying, that they would, normally they would be the ones that would, help us get entree to the folks that we want to survey, but I just don't know how receptive there would be to that kind of information being out.
That's a good point, Chris. This is, I think I talked with the doctors in the front line, and the other day, they talked about how the previous traditional practice doesn't work, and how to improve the current clinical flow. But I think that the clinical duties are hectic because it's too many patients and the burden of the healthcare systems right now. And I totally think this kind of survey is a great idea. And our Penn State site, we're happy to participate and help these efforts.
Right. There are obstacles, but I think it could be a valuable contribution to
it could be done now, could be done through the process, and even after we can still connect data. Yeah, that's a good point.
You can promise these institutions anonymity. You can promise to give them back their data so they can find their data in the matrix, but and promise them that their data won't be shared with other places. But I think if they can view their clinicians' views of their organization with those from 10 or 12 other similar institutions and other types of institutions, that kind of information gathering for CEOs, for others, could be very valuable than just relying on each organization to do it themselves, because they don't know how they compare with or what they can learn from other organizations.
Yeah, definitely. Very valuable.
I like this idea of it being a broadly collaborative thing too. I think each of our centers, each of our sites have people with experience in survey work and analyzing survey data. So by all means, let's see if we can get a group collective response on that. I think it's wonderful. Okay. Any other points of discussion for now before we adjourn?
I would just say that I think this has gone rather well for our first attempt. I think we should do this again relatively soon, perhaps with some of the same outside participants. I've been tracking the participation. We got up to about 85 people at one point. Now it's down to about 40, which is understandable, but that's pretty good for a first time around. We had a lot of guests. I think that's good. We still have some guests online. So first try, good job, I think.
Thank you. Thank you. And sincerely, thank you very much. Many people contributed to the conversation and to the preparation for this. I'm very happy with how this has gone. Thank you all. I'm going to just point out a couple of CHOT upcoming things. This is the last stuff I have. We will have meetings. They will be done virtually until for foreseeable future. But this is not our annual IAB spring meeting in which we present presentation proposals. We get feedback, we get answers. That will, I think, probably we'll want that to take place here in the meantime relating to these sorts of efforts. And by the way, CHOT members who have already put in a lot of work to develop proposals that don't say COVID on them anywhere, by all means, those are still valid, but I would ask you to consider taking those great ideas and pushing them to the side if you find you can contribute, in a more direct way for the COVID things. But I do recognize a lot of work went into a lot of those proposals, so they're also going to be considered. Also, we are, yes, please.
I would say that don't be too quick to say this is not your meeting. I think NSF is going to be very lenient, and you may not want to be throwing a meeting even in May. You want to stay focused, and this may fulfill the requirement. I think it will. And your next meeting may be 4, 5, 6 months from now. Don't feel obligated to have to produce a more typical kind of a general meeting. This, I think, can suffice. I'm going to submit a meeting report for this event.
Okay, great. Thanks, Greg. Okay.
And we don't need to do extra stuff right now.
Okay. Okay. Well, we will, though, want to be communicating with our industry members who couldn't be here today,
For sure.
Of course, with these, potentially new directions that we can take it. Thank you very much. Also in the fall, when life goes, comes back to somewhat normalcy, we're hoping, then we will get that awesome chance to visit our friends at University of Louisville for our fall in-person meeting. We're hopeful. And I'm hopeful also that the fun activities they had planned can then just be postponed and revisited at that time. But this is where we'll have our standard fall meeting format there. So with that, I have nothing else to add for now. We have lots on the email world that will be coming. Does anybody have any closing thoughts or comments? Anything from Lauren that we need to make sure we say?
I would say many thanks to Tom, Lauren, and Tamu team for putting together this conference call. And yeah, thank you very much.
Well, it was a large group effort, but thank you, Hui. Yes.
Yeah, I think it went really well. I'm very pleased. Thank you for everyone who quickly made this happen. Yeah, you didn't miss anything, Tom. Excellent job. Thank you all for joining us.
Okay. Thanks, everybody. I will stop the sharing here in a moment. We will post the recording. I wish you all a very nice rest of the day and weekend, and stay safe and healthy. And thanks for helping, everybody. All right. Take care. Thank you.
Thank you.
Bye-bye.